Dear colleagues, this is my great pleasure to start and introduce the first session. This is the joint session by Polish Presbyopia Club and International Society of Refractive Surgery. And speakers to this session are members. Many of them are members of the International Society of Refractive Surgery. And as I already mentioned, some of them are also members of our International Scientific Committee. So the first lecture will be delivered by Professor Noel Alpins. It will be on EDOF versus trifocal IOLs, the patient's experience. Then Professor Pablo Artal will speak on inverted meniscus IOLs to improve peripheral vision. Then Professor Z Reinstein will speak on options and considerations for the correction of presbyopia in the absence of cataract. And Professor George Beiko from Canada will speak about monovision in presbyopia correction. Then we will have a discussion which will be co-moderated by Professor George Beiko and me. And then we'll have 3 more lectures by Professor Kałuszny from Poland on presbyopia correcting IOLs and postoperative astigmatism, Professor Volodymyr Melnik from Ukraine on multifocal or EDOF IOLs, how to prevent disappointment of the patients, and Professor Valery Sedyuk from Ukraine on comparison of visual functions and the degree of satisfaction with vision quality in patients after implantation of diffraction, refraction, and diffraction intraocular lenses. And then we have another discussion at the end of the session. So now it is my great pleasure to welcome Professor Noel Alpins from Australia.
Well, thank you so much, Andrzej. It's such a pleasure to be speaking on this Presbyopia meeting, and I do appreciate participating in this excellent meeting with such many speakers from different parts of the world. Can I have my first slide, please? I'm just on the program here, Andrzej. I'm not, I don't see the slide yet.
Poprosimy o prezentację. Oh.
That's it. I'm good. So I'm speaking about extended depth of focus lenses, or EDOF lenses, and versus the trifocal IOL. And we're talking about the patient experience. And we actually sent a questionnaire to all the patients, and they've returned it with quite an excellent response. So my disclosure is the Assort Surgical Management Systems program, and which we used during the study. So the aim of the study is to compare patient satisfaction with the trifocal fine vision IOL, or the POD FGF, which is a hydrophobic lens, glistening free, versus the EDOF Techna Symphony lens IOL after phacoemulsification cataract surgery. So the study compared the visual outcomes and compared between patients at far, intermediate, and near distances. So looking at the first lens, the Johnson & Johnson Symphony IOL, the echolets are on a side view of the lens, the echolets are on the posterior surface of the lens, and these echolets bring the light to an elongated focus. So the anterior surface of the lens is aspheric, and the posterior is a diffractive pattern that elongates the focus, and this enhances the range of vision. Now the Physiol fine vision trifocal IOL, also known as the POD FGF. This has got the diffractive pattern on the anterior surface as against the posterior surface in the other lens. It's aspheric anteriorly and it's hydrophobic. And it gives you an intermediate power of 1.75 add for intermediate and for near 3.50. And it splits the light into distance, intermediate, and near focal points. So when you look at these two lenses side by side, you can see that the Techna Symphony EDOF lens, extended depth of focus lens, has 9 rings. The fine vision trifocal has 23 rings to achieve its goal of the trifocality. So in fact, the Technis Symphony lens has less rings, and therefore it needs higher steps to be able to accomplish the multifocality. And an article was well written by Noel back in 2016 describing the differences. So this is a retrospective study, only one surgeon, myself, using topical anesthesia, a 2.2 millimeter diamond blade clear corneal phaco incision. For the biometry, we used either the IOL Master 500 or 700. And with the cataract surgery, we had 93 eyes that had the Technis Symphony lens, and we had 49 eyes that had the Physio fine vision trifocal. So these were sequential. In the earlier part of the series was the Technis, and the second part of the series was the fine vision trifocal. So post-operatively, the patients had Maxidix 4 times a day for the initial week and then tapering over the next 2 weeks. And we examined the patients for these results at 4 weeks, looking at uncorrected distance vision, uncorrected near vision, uncorrected intermediate vision, the manifest refraction, slit lamp examination, intraocular pressures, and keratometry. And the substance of this paper is about the patient satisfaction, which was evaluated using a questionnaire which we sent to the patient some months after the surgery. And we had overall a 70% response from both groups of patients. So we look at the demographics for the Symphony and the trifocal fine vision. All the parameters were equivalent between the two lenses as far as age in years, sex, axial length, simulated keratometries, and the minimum and maximum keratometries. The patients we included were really cataract patients who were requesting independence from spectacles for distance and intermediate and potentially for all distances. And they had to have a potential visual acuity of logMAR 0, which is effectively 6/6 or 20/20 visual acuity. So we excluded patients who had unrealistic expectations, patients who just wanted clear vision without any side effects, any patients who had ocular pathology beside the cataracts. We excluded patients in this study that had previous refractive surgery, although we have performed patients, trifocals and multifocals, who have had refractive surgery in the past. Anyone who had preoperative astigmatism of more than a diopter or corneal higher order aberrations of more than 0.30 weren't included in these groups. Preoperatively, there was a very wide range of spherical equivalents, both for the Symphony and for the Pod GF. Preoperatively, it was postoperatively, a number of weeks since the procedure, up to 2 years, the two were equivalent in their spherical equivalence over time. And looking at the results preoperatively and postoperatively, the dark blue line represents the visual acuity of 20/20 or 6/6. These were equivalent between the two groups as far as their unaided distance visual acuity. So where the differences lie, not in the far distance, which was equivalent at 0.10 versus 0.13 between the Symphony and the fine vision. The intermediate vision was also close to equivalent with 0.22 versus 0.20. But the near distance vision between the two groups was quite different. The Symphony 0.11 versus 0.04 in the fine vision. So at 1 month, the uncorrected vision between the two groups was different at the near vision distance. So we asked the patients 6 questions on this survey, and I'll go through each one separately. So has the surgery changed your vision? And looking at the right-hand side of the graph, in the Pod in the blue versus Symphony the Pod trifocal fine vision had a greater number of patients who recorded a much improved 80% versus about 62%. The second question which we asked the patients is, how is your quality of vision in the daytime? And the number of patients in the pod group who volunteered excellent on the right-hand side of the graph shows between 75% for the pod fine vision group to about 45% in the symphony group. The third question we asked them is, how is your quality of vision at night? So it was pretty equivalent when the answer was excellent, but at the good level, there was some superiority in the symphony group, seemed to prefer their night vision over the pod vision at night in their quality at night. And so the fourth question is, are you happy with your intermediate vision? And the answer always was given more frequently by the pod group of about 65% versus about 45%. So the pod group seemed to be more happy with their intermediate vision, middle range vision, 25 to 40 centimetre kind of distances. The fifth question was, do you have problems with bright lights at night? Which is a different question than we asked earlier of just, are you happy with the quality of vision? This is actually, do the bright lights trouble you? And the answer always was given far more frequently in the pod group, 40% versus only about 15% with the pod group, whereas the symphony had the 40% of more people having problems with their bright lights at nighttime. And just as a general question of how happy are you with the overall experience of your surgery, which is a kind of a general question about the whole experience, not just the lens itself, but the whole episode from start to finish, including the surgical procedure, there seemed to be a higher proportion of pod patients who are happier at about the level of 75% versus about 55% of patients in the symphony group. So when you look at all these in summary, in the second, third and fourth question, the physiology vision was better than the Techno Symphony for quality of daytime vision, intermediate vision and interference of bright lights, whereas perhaps the Texas Symphony had some small superiority in the quality of vision at nighttime. So why do I choose fine vision trifocal now? Because this is the one that I said was the more recent surgeries, and the previous surgeries, what we used to use was the Symphony lens. It does give excellent distance visual acuity from day one. It's got very good intermediate vision. There's minimum halos and glare issues, although this was something which we were concerned about at the start because it was given some publicity about the halos and glare, but it didn't really crystallise into patients' discomfort. I think the big benefit here is the very good near visual acuity, which the fine vision has over the Symphony, and it just centres in the capsular bag without having to really adjust it. It just seems to, the haptics seem to bring the centre of that lens to the centre of the pupil every time without having to manipulate it one way or the other. And importantly, with the pod lens, there was no glistenings, but neither were there with the Symphony lens. Well, the contraindications, we all know, any macular condition, higher order aberrations of more than 0.3, patients who had preference for excellent distance vision compared to near. So, for example, you'd be cautious about a truck driver or a bus driver. I think you're even cautious about golf players because they want to be able to see the flight of the ball, which is more of a problem with the lenses that have rings. You can lose some contrast sensitivity. Any patient who has unrealistic expectations, we wouldn't be able to deliver with any certainty to their expectations. We would certainly want to exclude those patients. And patients who had either irregular or keratoconic corneas, But of course, their higher operations were probably going to be more than 0.3 in any case. Just looking at a couple of other studies that looked at binocular defocus curve comparison, a meta-analysis of more than 1,300 eyes between Liu and Dong. It really showed there was comparable distance and intermediate and better contrast defocus curve with the trifocals get towards the near distances. And there was a longer range of defocus. The extended depth of focus was greater with the trifocals, and particularly in that range between 25 and 40 centimetres of unaided vision was able to be more independent with the pod trifocal lens. Looking at binocular contrast sensitivity by Remonteria and Capello back in earlier this year, they had 23 versus 32 eyes, and they found a better contrast with the fine vision compared to the Symphony, and this was statistically significant, which you can see in the Symphony being the blue line and the fine vision being the orange line on the graph. So, in summary, the results of what was a patient satisfaction survey where we asked 6 questions, 4 of which we displayed as a major comparison. The fine vision trifocal IOL was better at intermediate and near distances we have found in the Technis Symphony lens, and the fine vision trifocal IOL had less problems with lights at night. And so this has really become my go-to lens for any patient who is seeking multifocality in implants. The trifocal has now become the lens that I go to for patients who are looking for independence from spectacles for all distances, intermediate distance and near. So thank you for your attention. Thank you for the invitation, Andrzej, to present. It's such a pleasure to come to Poland, even if it's only virtually. I will certainly try and get myself there sometime soon once we get through this pandemic. This is very much a celebration day for us here in Melbourne. We've had something like 260 days of locked up. So we're the most locked up city in the world. And just today, the doors are open, we're unlocked, and we can now mix again now that our vaccination rate's raised. So it's a lot of celebrations here in Melbourne today. Thank you all.
Thank you, Noel, very much for this great presentation. And it's indeed a pity that we must meet online, and hopefully, well, in the nearest future, we might be able to have you and George and other speakers in Poland at one of our next meetings in Poland. So
be delighted.
Thank you again. And now we move to the next presentation by Professor Pablo Artal, and this will be delivered as a video. However, Professor Artal will be present with us during the discussion part.
Hello, I'm Pablo Artal from the University of Murcia in Spain, and I'm going to talk to you today about an issue that is not very well acknowledged in cataract surgery, but is related with peripheral vision. I would like first to acknowledge the organizers for inviting me to participate even remotely in this meeting. And we are located in Murcia in southeast Spain, and this work had been basically performed in my laboratory at the university and also at the startup Boptica, developing the ART IOLs. Well, you know that there have been a lot of advances in intraocular lenses, but all current lenses, they are still not adequate for peripheral vision. And the reason is very simple to understand. Intraocular lenses today, they are very thin lenses, and there is a very good reason for that. It's very good for the surgical procedure. but the optical role is to actually substitute a very thick lens, as is the crystalline lens. So the main difference is going to be a really very significant problem in the image quality in the periphery. And in this slide here, you have a comparison of a ray tracing for different angles in the retina, where on axis, basically both, of course, the natural lens and the standard biconvex IOLs, they are doing well. But at the periphery, our eye is really doing a much better job optically than standard intraocular lenses. Actually, we know this from several years because we published a paper in the journal IOVS several years ago, where we basically measure peripheral refraction in eyes still with the natural eye. So we select a group of patients with eye that there was still non-operated and the other eye with a standard intraocular lens. We basically discovered that this is eccentricity, this is spherical refraction, that in the natural eye, the periphery was really very good control, the curvature, but field curvature, but in the pseudophakic eyes, there was a significant defocus. In addition, peripheral astigmatism was also larger with the pseudophakic eye with the standard intraocular lenses as compared with natural eye. So we knew that the optics with the standard lenses was not good in the periphery. And for decades, basically every IOL had been basically designed only for a small part of the visual field. We believe, and there is a lot of studies related with peripheral vision, we believe that actually when there is problems with peripheral vision, this can be a very significant problems for patients. In particular, there is an increased risk of falls, poor object recognition, driving difficulties, and at the end, a limited freedom of movement and loss of independence. So peripheral vision for patients are really very, very important. So we recognize this problem, and during several years, we had been actually working in a new concept, a new intraocular lens that, of course, have to be thin because we don't want to compromise surgical procedures. But basically, we designed an intraocular lens with a meniscus shape that somehow mimic the natural lens to provide optimized field curvature and better vision in the periphery. I'm going to talk to you a little bit about this. So this is the shape, inverted meniscus shape. These lenses are, the name is ART IOL, and they are already CE-mark and they are implanted in, I'm going to tell you a little bit more about that in Europe. And these are the specifications. Basically, they are hydrophobic acrylic material, very standard, everything except the inverted meniscus shape. Before starting the implantation in subjects, in patients, we did a lot of testing in simulation and optical bench. I'm going to show to you some of the results of this. These are in a model eye, the point spread function, the image with a standard for a 45 degrees in a standard intraocular lens. You see a lot of astigmatism, and with our IOL, that is really much better. We also perform calculations based in images in a model eye. So this is using real lenses in the model eye. And on axis, we compare with a standard biconvex monofocal. And you see the images are very similar and they are good on axis, what we were expected. However, when you go to 40 degrees, our inverted meniscus lenses, these are really much better. So theory and optical measurements in model eyes show that this was really working. So we basically started we started last year, actually at the same time of the pandemia, basically, so we were relatively slow with implantation, and we already have around 1,000 art IOLs implanted in Spain, and this Dr. Pedro Tanya and Jose Maria Marin had been the persons of Alpins clinic implanting most of these lenses. I'm going to tell to you a little bit about the clinical results, that they are really fantastic. First, well, how these lenses are sitting. So you can see this anterior segment OCT of one of the patients, and basically this is the situation. So it's a kind of nice. These lenses are sitting a little bit behind, what is also good optically. So we wanted to really understand the impact in the periphery, so we measure both peripheral defocus and peripheral astigmatism. In a significant group, we measure 158 eyes with art IOLs, and we use a group with a control group with a standard biconvex intraocular lenses with 61 eyes in black. So this is what's happened. So basically, our lens is controlling peripheral defocus much better. For this is 40 degrees here, as compared to standard bifocal. So there is, for 40 degrees, there is around 2 diopters off. And astigmatism, there is all astigmatism in our eye, right? And so with these lenses, we are also reducing from 1.5 to around 3 diopter in the standard IOL. So we really demonstrated that what we predicted in the theory was actually happening in patients. Of course, you can tell, well, this is better optics, but this is in the periphery, and the visual system in the periphery has a very low resolution because the retinal sampling, the ganglion cell sampling, and so on. So what's happening with visual function? So we also measure contrast sensitivity. Basically, we measure contrast detection sensitivity at 45 degrees. It was a very simple psychophysical test where subjects were fixating and there appear a target at 45 degrees. And again, we compare the results in the control group with biconvex lenses and the meniscus group. And well, you can see there is a significant improvement in contrast sensitivity with our lenses. So better optics and also better contrast sensitivity. How this really affect functional vision and daily life? Well, we don't know yet. So that's, to be honest, we know that there is better optics with the lenses, there is better contrast sensitivity in the periphery. We don't know how this really can affect. We speculate that this can have a very significant impact. And to understand this a little bit better, you can see this simulation. This is a simulation, I have to say. But this is, imagine somebody just going downstairs and basically looking ahead, and there is these steps around 40 degrees. The image of these steps with a standard IOL is something like this. With our lenses is much more visible. So we believe that this task will be really better, and of course we need still to demonstrate. So basically we have these new lenses, a new concept that improve peripheral optics and peripheral contrast sensitivity, and we believe functional vision. Very briefly, it's that, while these lenses are not only good for peripheral vision, we also design with something else on mind. Basically, this is a family of EDOF lenses, extended depth of focus lenses. So the idea, it's very simple. Basically, they are refractive EDOF lenses, and there is 4 models, all meniscus shape, and with different amount of asphericity from 25 to the 70, basically increasing depth of focus at different amounts, basically. We also have very nice clinical results on that. This is our monocular through focus curve in a group of patients, and you can see that they are all behaving like EDOF lenses for the very mild, what we call R25, and medium R40, And kind of a strong EDOF is the R70 that actually is getting a J1 at a target of 2.5 diopters. So we combine these two features, inverted meniscus, customized EDOF. So in summary, these lenses that they are CMAR, they have hydrophobic material, they are of course normal, easy to implant. We already have excellent clinical results. We demonstrate improved peripheral vision and reduce oblique astigmatism. These are also customizable EDOF lenses. And well, we are convinced that this is a really unique optical technology for a better quality of vision of your patients. So this is ready for your patients. People are starting to implant more in Europe, and I think this will be available in other countries because they are CMAR, and with these two specific feature, right? Paying attention to peripheral vision and improving and customizing. You can select EDOF depending on the needs of your patient. So thank you very much for your attention, and I will be this has been pre-recorded as you know, but actually I will be on live just to answer any question or comment. So thanks again, and we just let's talk in a minute in person.
Well, thanks very much for the invitation to speak. I'm going to talk about laser vision correction for managing presbyopia in the absence of my financial interests. I have no financial interest in Presbyopia. So presbyopia correction is, like I've been asked to talk about corneal correction of presbyopia. And the fact is that this seems to be some kind of, everlasting existential discussion between cornea and lens, as if, that's the two planets and they shall never meet. I want to convince you at the end of this that, in fact, it's not two planets. We're actually talking about 3 planets. And those 3 planets are not cornea and lens. They are multifocality, spherical aberration modulation to induce extended depth of field, and monovision. So multifocality, everybody's very familiar with because these modern trifocals and quadrifocal lenses are fantastic. But remember that corneal inlays were multifocal corneas, and we've had multifocal ablations for a long time. Monovision is well known to cataract surgeons and is performed by LASIK. But I want to talk about today is extended depth of field by modulating spherical aberration, something that I came across serendipitously in the early 2000s, and I worked on this algorithm, which then, as I said, became Presbyon for Carl Zeiss. And what this does is it modifies binocular vision, and it creates binocular perception, stereo acuity is maintained, and in fact, the IOL industry is now starting to copy this 15 years later. I didn't get credit for that, but that's okay. So multifocality initially was what? It was near in distance in one lens, or it was intermediate in distance in one lens, and you'd mix and match. Now we have trifocal lenses, which give us 3 different distances, but it's 3 discrete distances, right? The thing about diffractive optics is that they degrade vision, and this is supposedly, as we were told in 2014, a non-vision degrading IOL. It's an EDOF lens apparently, but it's diffractive, and so patients present complaining of rings around lights at night, and it's unpleasant for them, and some of them don't tolerate it. Plus, they don't get that much reading vision, and they get reduced contrast sensitivity. So, not a great package, diffractive optics. So let's go to multifocality, and I'm going to talk about the less common version of it, which is corneal multifocality. And we have a very beautiful example of this in the industry, where one company developed what's called a bispheric multifocal ablation, and there's a central add of 2.25 diopters in the middle of the cornea. So it's basically a central island, but it causes a lot of loss of best spectacle corrected vision. And so these same investigators went across and did less add, and they got better safety, but they still were getting 5% loss of 2 lines, which is still unacceptable. So they put in even less add, and used a small anisometropia to cover the field because of the less ad, and so they got down to better safety. But it's not a popular procedure, and the surgeons that have this laser, which is a fantastic laser, don't use this program very much because it does affect the quality of vision, decrease contrast. So multifocality in general has these problems, right? It affects night vision. It reduces contrast by definition. That's how it works. It's tolerated very well by about 70% of patients, and not so well by 30%, and very, very poorly tolerated by a few percent. And if you don't like it, there are limited options for what to do next. Let's go to the monovision side of the equation. And I'm not going to go a lot into monovision, but the point about monovision, it really is mono. It's one eye for distance, one eye for near, and that means that the distance vision of the near eye is very blurry, and the near vision of the distance eye is very blurry, and the intermediate vision is blurry. So about 50, 60, 70%, depending on which study you look at, tolerate monovision. So that's another problem, is that the tolerance is poor. And these challenges of monovision, loss of stereoacuity, loss of summation, neural subtraction when bilateral, but when binocular, and like I said, only a few percent of patients you have to do a contact lens trial. It's really a bit of a pain to get through the process. Graham Barrett for many years was talking about modest monovision, which improved on all of these challenges, but it gives less near vision. And he was working on the fact that if you have an anisometropia of less than 1.3 diopters, you'll still get summation. You get neural subtraction after 1.3 diopters, but then finally you get suppression at 3.5 diopters of an anisometropia, but that's giving you zero intermediate vision. So this modified monovision is good in terms of increasing tolerance, but you still have distance vision loss from neural subtraction and from the loss of summation. We also know that anisometropia of 1.5 diopters or more will break stereoacuity, and then you can't fix it, right? It's done. So this near vision acuity compromise means that this option of monovision is okay. It's tolerated better, but the intermediate vision is poor or the near vision is poor, and you have to kind of titrate between the two. Now we're coming to spherical aberration, and the fact is that this is a naturally occurring aberration in the eye, and therefore it's a naturally filtered operation of the brain. And this is not multifocality. It's not more than one focus in the eye. It's an increase in depth of field, really. And you know that you've seen this before. I've shown you these defocus curves, and minus 150 is very blurred, about 2100 vision. But when you add spherical aberration, it gives you about 2060 vision. And the brain doesn't have to put those two images together with the spherical aberration because the brain filters it. The brain is actually putting together two quite similar images as opposed to the disparate images that have to be some kind of alternate suppressed in monovision. And this beautiful study by Carolina Rocha, she showed that it didn't matter whether the spherical aberration was positive or negative, meaning this is not a pupil-dependent issue. If you increase spherical aberration within certain range, you will get an increase in depth of field. And that's the therapeutic range. If you push the spherical aberration higher than that, that's the toxic range. And it was the toxic range that I was treating with the Waska and the MEL 80 that reduced it modestly, the spherical aberration, but the patients had normal contrast, and that gave me the idea of using spherical aberration for depth of field. We're able to get about a 1.5 diopter depth of field with the amount of spherical aberration that's tolerated, 0.6. And so we're not inducing a loss of contrast because we're keeping that spherical aberration controlled. So we use a micro anisometropia to get a depth of field. And so the dominant distance eye has about a minus 0.75 at intermediate. And the near eye set to minus 150 sees as if it's minus 0.75 at distance, but minus 2.25 at near. And so what this does is it really gets rid of all these challenges. And it gives you binocular vision as opposed to modest monovision. So this is a binocular vision post-op. And it means that the intermediate vision is good in both eyes. The distance vision of the near eye is better, and the near vision of the distance eye is better. So 97% of the patients tolerate this setup. Here's 395 patients across myopia, hyperopia, and emetropia. And you know, when you have a -150 defocus, you'd expect 2100 vision, but in these patients, 80% of them are 20/60. Monocularly, 92% are 20/20, and that increases to 96% when you add the blurred eye. So I'm showing that we have neural summation. We also demonstrated in our safety and efficacy study of stereo acuity that 3/4 of the patients had 100 seconds of stereo, and 100% of the patients had 400 seconds of stereo. Well, that's threading a needle only requires 800 seconds of stereo. So how do you do this procedure? Well, you've got your specialized testing, which takes about 5-10 minutes in the clinic, and that qualifies 97% of the patients that walk through the door. And then you perform LASIK. And we know that LASIK is very accurate. We published our results more than 10 years ago for myopia up to -850, hyperopia to +6, and emetropes. And as you can see, practically all of the patients end up 20/20 J5, and the vast majority of myopic and ametropic patients end up 20/20 J2, with 75% of the hyperopes. So the fact that we don't lose contrast, the fact that it's now being reproduced around the world by other centers and other publications, means that we now have a fairly convincing argument that multifocality has disadvantages, monovision has disadvantages, and spherical aberration-induced depth of field with a microanesometropia doesn't really have that many disadvantages. And the only disadvantage is the eyes are slightly different. Well, if they're slightly different, then you just put on a pair of glasses if you want both eyes for distance. So you've learned. Finally, I just want to finish off with this discussion about cornea and lens. How do we decide? Well, obviously, if someone has a cataract, then you can increase their transmission to the 85% transmission of a trifocal and make them very happy. But if you take someone with 95% transmission and bring them down to 85%, well, that's not very happy. So that's different. We're treating these two populations as if they're the same, and they're not. Trifocal lenses work extremely well in cataract patients. Now, this younger population from 40 to 60, they don't have cataract. And you can do an OCT, but 1 in 6 of them are going to develop macular changes. And so you're kind of condemning them to lower contrast earlier because you put a contrast inhibiting lens. In the UK, only 30% of people get to cataract surgery. So saying that we're going to do this surgery because you're going to get a cataract anyway is not strictly correct. And I'm not going to mention, but I am going to mention these, highly unusual but catastrophic risks of cataract surgery. But we do need to mention retinal detachment, because the retinal detachment rate is about 7 times higher for a 50-year-old than it is for a 70-year-old after phaco. The other thing is that there's this concept that you're permanently correcting the vision with an IOL. Well, yeah, I mean, up to the age of 40, the cornea doesn't change, but you put that IOL in the 40s, and that's when the cylinder starts to shift in the cornea. In fact, large studies showing that in the next 5 years, every 5 years, the astigmatism is going to change by at least a diopter in a third of the eye. So back to deciding between cornea and lens, and the answer is you've got to use a transparency measurement that's objective. And the OSI is a very nice measurement of cataract development. And as you can see, we performed Presbyon in many patients who are over the age of 60 because their transparency was good. And of course, they're warned that they may need a cataract, but we don't perform Presbyon in patients who have cataract. Once we started teaching, I had one surgeon who said, well, could I have it done? And I said, why don't you come to the next course and we'll do it the day or two before, and you could talk about your experience at the course. And that led to a domino chain reaction amongst surgeons, where we ended up, so far, we've got at least 20 surgeons that we know of that we've treated. And I took my own medicine a few years ago. I now feel as young as I did when I was at Club Med playing the saxophone during my medical school breaks in the summer. So in summary, Presbyon offers a bilateral simultaneous procedure that is done in 10 minutes. It corrects emetropic presbyopia, myopia over a huge range, cylinder corrected very accurately. Everything is placed on the visual axis by an eye tracker. There's no night vision disturbances. Any disadvantage that might be there because of the slight anisometropia is instantly reversible by a pair of glasses. It's tolerated by more than 95% of the people that walk through the door. And it maintains functional acuity, so you can understand functional stereo acuity. So you understand why so many ophthalmologists are opting for it. When you look at the table of options, clearly EDOF is better than multifocality or monovision, and EDOF in the cornea is the safer option when considering presbyopic treatment in the absence of cataract. Thank you.
This is my great pleasure now to introduce my co-moderator, Professor George Beiko from Canada, who will speak on monovision. Please, George.
I think you can play the video because there's...
Hello. Firstly, I'd like to thank the organizing committee for inviting me to be part of this symposium. Today, I will be talking about monovision. I have no financial disclosure related to this topic. As cataract surgeons, we are involved in restoring vision to our patients. Cataract surgery has evolved from the restoration of vision through the use of couching or aspiration, and more recently, extracapsular cataract surgery, to visual rehabilitation, in which we have provided our patients with glasses, contact lenses, and intraocular lenses in order to allow them to see better, to maximizing their visual potential through the use of complex instrumentation, including optical biometry, topography, tomography, aberrometry, and anterior segment OCT. And most recently, we are trying to provide our patients with functional range of vision in order to allow them to see at distance, intermediate, and near. We know that in younger patients, this is achieved through accommodation. Accommodation involves contraction of the ciliary body, lenticular changes, and changes in refractive index. We can measure accommodation using instrumentation such as the COAS system. Here's an example in which we've used the COAS system in order to record the changes that occur when a stimulus of 6 diopters is presented to a young patient. Using the COAS system, we can measure the accommodation in phakic and pseudophakic patients, and our findings mirror published data in which there's decrease in accommodation with age and essentially no accommodation present after the age of 55. In pseudophakic patients, there's also no appreciable accommodation that can be measured. So, if our ability to see at near depends on accommodation and we have no accommodation, then we must use other means to achieve this. And these include residual myopia, the pinhole effect, corneal multifocality, depth of field of focus, astigmatism, and recognition or motivation. My goal today is to talk about monovision specifically, and the goal of treatment in monovision is to provide patients with clear vision both at distance and near. And the main strategy for this is to use planned myopia, correcting one eye for distance vision and the other eye for near vision with myopia. But what we may not appreciate is that other strategies come into play when we use monovision, specifically the pinhole effect and spherical aberration. Let's take a look at these. We know that the pupil size decreases with age. If we look at the effect of a small pupil, we know that this facilitates the pinhole effect, which results in extended depth of field. And specifically, we can measure this effect, and what we have found is that a 3 millimeter pupil allows for 1.5 diopters of depth of field, and a pupil less than 2 millimeters allows for 2 diopters of depth of field. If we look at the impact of senile cataracts on vision, and in this paper by Roca and colleagues, we found that elderly patients with nuclear sclerosis have been shown to have a wider depth of focus, mainly as a result of the myopic refractive shift, but also because of positive spherical aberration. So let's look at spherical aberration. We know that the lens spherical aberration goes from negative in young individuals to positive in elderly individuals. The impact of a nuclear cataract is that it induces approximately 0.4 to 0.5 microns of spherical aberration. The corneal spherical aberration we know does not change over time, and this has been measured by my group to be an average of about 0.27 microns. So the total spherical aberration of the aging eye is due to the change in the lenticular spherical aberration and measures approximately 0.5 microns. What is the impact of the spherical aberration? Well, it can increase the depth of focus or depth of field. And in this study, again, by Roca and her colleagues, we find that 0.5 microns of spherical aberration results in 1.5 to 2 diopters of depth of field. So, spherical aberration of its own can increase depth of field, but causes some distortion of the image. How can we balance this? Well, in studies that were done in corneal refractive patients, as well as in cataract patients, we have found that, generally speaking, about 1/4 diopter of sphere or defocus balances approximately 0.1 microns of spherical aberration. So we can have this interaction of spherical aberration and defocus work to our advantage. So, as I've shown previously, the impact of spherical aberration, and if we look at the impact of defocus or myopia, we see that the vision is blurred, but when we put the two together, we actually get clear vision for distance. In this work done by Graham Barrett, also looking at the same thing, so positive corneal spherical aberration and a plano refraction gives you good distance vision, but as soon as we balance the positive spherical aberration with myopia, we get an extended depth of field. So we know what the interaction is between spherical aberration and refractive error. We should also look at the impact of pupil size. This is a study that we undertook in 2009 using the ZMAX system, in which we were able to measure the impact of all three factors. And what we found was that the refractive error was independent of pupil size in its impact on vision, whereas the spherical aberration was dependent on pupil size. Thus, our conclusions were that refractive error can compensate for spherical aberration at larger pupil sizes, but will introduce defocus at smaller pupil sizes. What are our options today when we do cataract surgery? Well, we know that the population corneal spherical aberration is approximately 0.3 microns. We have positive spherical aberration lenses available to us, and the range is approximately 0.1 to 0.2 microns. So if we were to use refraction to balance for this, we should induce a myopia of greater than -1.25 to balance this positive spherical aberration. Negative spherical aberrations tend to compensate for the corneal spherical aberration, so that the total spherical aberration of the system is 0. Therefore, we should target plano in these patients. And in patients who are getting an aberration-free lens and no induced spherical aberration, we would use the refraction to balance a corneal spherical aberration, and so we would target -0.75 diopter. We should also look at the impact of this anisometropia on stereo acuity, and thankfully studies have shown that anisometropia up to -1.25 diopters results in minimal effect on stereo acuity. So my strategy is to use an aberration-free optic. I target plano in one eye and -3/4 of a diopter. So using this strategy, we'll be faced with two situations. In the first situation, the pupil size will be greater than 3.5 millimeters, and we know this, that spherical aberration will have an effect. So in this situation, the minus 75 diopter target eye will be used for distance, and the plano target eye will be used for near because of positive spherical aberration. In the other situation, in which we have pupils which are less than 3.5 millimeters, the spherical aberration has no effect. So in this case, the plano target eye will be used for distance, and the myopic eye will be used for near. So if we use this strategy of mini monovision, what is the outcome? Well, the distance visual acuity is approximately 675, and the near visual acuity is J2, J3. How does this compare with the extended depth of focus lenses? In this work done by Carolina Roca and colleagues looking at extended depth of focus lenses versus an aberration-free lens, they were able to determine that the extended depth of focus provide 20/25 vision at near, but interestingly enough, the aberration-free lens provided 20/30 vision. So, my personal experience looking at various situations, if I use an acrylic one-piece lens and target plano in both eyes, I get excellent distance vision, acceptable intermediate vision, and no near vision. However, if I use the mini monovision strategy, I lose one line of distance vision, but I gain an intermediate and near vision, and this gain is comparable to the so-called accommodative IOLs, which we've looked at in the past. Most recently, looking at diffractive acrylic multifocal IOLs, in which I target plano in both eyes, I find that the distance vision is comparable, the intermediate vision is comparable, but the near vision is slightly better in the multifocal IOLs. What is the experience in? Well, looking at refractive multifocal IOLs and monovision of plano -2, there was no difference in maximum reading speed, but monovision had a significantly better mean critical character size and reading. Looking at this study in which monovision was compared to a diffractive multifocal, no difference in distance or near vision, but monovision has a significantly better intermediate vision and less dysphotonia. In this study out of England, comparing a diffractive multifocal with monovision of -1.25, no difference in distance vision, better intermediate vision for monovision, and better near vision for multifocals. However, multifocal IOL patients were more likely to undergo IOL exchange. In a Cochrane review, 20 studies were reviewed altogether, and monovision resulted in no difference in distance vision, intermediate or near vision. Multifocal IOLs had the advantage of reporting less spectacle dependence, but more likely to undergo IOL. So my strategy of increasing the depth of field using an aberration-free optic allows for binocular vision from 28 inches to infinity, and to this we can add the effect of the aging pupil, which increases depth of field, as well as the smaller pupil due to the synkinetic near reflex, which should increase the depth of field. And maintaining the mini monovision, we can decrease the effect in stereo. So the pros of monovision are functional vision at distance, intermediate, and near. The cons are some decrease in visual acuity from the best obtainable by one line, and possibly a decrease in stereopsis, but this is minimal and not functionally significant. Thank you for your kind attention.
Now we have a time for some short discussion. There are no questions from the audience on the chat panel yet. Of course, these can be given every time. So I would like to welcome all of our speakers and thank you again for your great talks. And I would like to invite George maybe to lead the discussion. But yeah, please, George.
Thank you very much. You know, it's kind of interesting that we kind of look at the situation and come up with our own approaches. I think what's interesting is that when we look at the impact of IOLs on vision, that we tend to forget the impact of age. So we did a study a few years ago when we looked at multifocal IOLs, and we looked at the 60s, 70s, and 80s age groups, and we found that the Snellen acuity was comparable in all of those patients for distance, intermediate, and near. But interestingly enough, when you ask the patients about spectacle independence, we found that that decreased. So although the 80-year-olds had the near visual acuity, and when we measured them, functionally they felt that they still required their glasses. And a lot of studies tend to ignore this. They tend to ignore the impact of age. And I'd like to know what the comments are of the other speakers on this and whether they've considered this.
Yes, please, Dan. Yes, you mentioned about the age. Yeah.
Yeah, George, that's a really interesting observation. And I think I'm just going to suggest that it goes to the point that I was making earlier in my talk about the fact that multifocals are inserted justified by a clear OCT scan. And a clear OCT scan is not a measure of retinal function, contrast sensitivity, and retinal function. So it stands to reason that if you're diminishing the transmission of light through the eye by you're losing light through diffraction, then you're essentially lowering the contrast threshold or raising the contrast threshold required by that retina to see the same image. So it makes sense that an older retina will not see as well as a younger retina with the same IOL, with the same optics. As you said, in the clinic, you're testing under standard lighting conditions, but at home, a patient is reading with their reading light, they might not be experiencing effect. What do you think about that?
No, I think I agree with you, and I think, you know, it's not only that, it's also their brain, even though the brain may see the high contrast images, it's still not able to function at the same level.
I hear a lot of background noise for some reason.
I'm not sure. Yeah, so I think it's just very important that we consider the age as a factor whenever we do these studies, and we should be looking at functionality as opposed to Snellen acuity alone.
Yeah.
There's no doubt that there's more interest in the younger group, in the patients that I address about do you want to have a multifocal lens or not. There's a lot less interest in people who are 65 or older because they live a more sedentary life. They're not as active, so they're happy to put on a pair of glasses to read with. Whereas the younger group are active and they don't want to be carrying glasses around with them, and they're more interested in distance and near, they're much more proactive about wanting to have that total independence of glasses, particularly if they've had a refractive error before. But I've avoided having to ever really take out any of these lenses because even though I've done quite a lot of lenses, I'm fairly conservative that if the patient asks like too many questions about it, I usually decide that, you know, if they ask that many questions beforehand, it's going to be treble that afterwards. And so you just try and avoid the patients you know you're going to have an issue with. And so fortunately, you just haven't had to take out lenses very often. And I think the acceptability of the EDOF, the pod lens, the trifocal lens has been such an acceptable lens. The acceptability, I think, has gone up higher. I'm much more comfortable about putting this lens into older people. I probably crept up to the age of 70 in people who have some interest in being totally free of spectacles altogether.
Noel, I think there's a subtext to what you just said there, which is that diffractive intraocular lenses compromise vision, and you're going to be very selective as to who you're going to do that for. And I think that George's message and my message and Pablo's message, and I'm sure Andrzej's message if he was giving a talk on this as well, is that we're moving away from diffractive optics. And because when you use full transmission lenses and you can play with an aberration that the brain can filter, called spherical aberration, you've got everything you need. All you need is a small anisometropia or more if you can tolerate it. And then you increase or moderate the amount of independence you have from spectacles without the bizarre optical compromise, which was introduced 20 years ago into the marketplace by companies, and which has had a very successful financial run, but has left a lot of patients with compromised, contrast. And the roost is whatever's going to come to roost, because when these patients get into their 80s and their maculas start to change, they're at a big disadvantage.
Yeah, and I think there's kind of, there's even been a broader aspect to that now, that if you don't really want to use a diffractive type lens, you've got the extended monofocal lens, for example, like the iHands, that's got a lot of the power on the back of the lens, and that gives you the intermediate vision where, maybe you have to put glasses on just for certain tasks, but for looking at supermarket prices, looking at restaurant menus, you can do that unaided. And then there's the other type of EDOF lens, such as the Vivity, that just has this little button of a lens in the center, but it doesn't have diffractive rings. So I would use that, for example, the Vivity in a golfer, because then they don't really lose that contrast for distance as much. So the lenses are kind of getting more varied in what your choices are. No doubt what you and George are saying is true as a laser type of alternative to having the mini monovision or blended vision like you've been describing for some time, Dan.
Well, I think that the lenses that you've just mentioned are not new. They are the last arrivals, this sea change of realization that diffractive optics were not the best idea. And I think that we're getting there. I mean, Pablo's lens, which, is a tiny little company, it doesn't have distribution, but he's thought about this, as an optical scientist. And, my interest in his lens is that he's providing levels of spherical aberration that are way higher than you have from the other manufacturers, knowing from all of the history that we have on corneal surgery that the brain is perfectly capable of absorbing 0.6 microns of spherical aberration without affecting contrast. And so Pablo's going in the right direction. The other big old companies that are kind of monstrously coming around with copycat IOLs are only duplicating the work that George has been doing himself, on his own, like the sort of manual job of calculating what the corneal spherical aberration is. And look, I remember as a resident in the 90s, I had patients who were plano and were reading small print after cataract surgery. And I asked my attending, and he said, "Oh, that's pseudo-accommodation," which of course means nothing. And of course, because the SA60 was spherical, and so it was inducing a lot of spherical aberration, and that's why the patients were seen in the Mount Sinai, clinic where the patients were getting free surgery on Medicaid. They were getting premium cataract surgery because they had near vision and distance vision because these were spherical lenses.
And then don't forget,
does this whole thing about, sorry, I just want to finish. Then there's this incredible detour that came when one of the companies says, "Oh, spherical aberration on the cornea is 0.27, so we're going to give you a lens that's minus 0.27, so you can make the spherical aberration 0, as if that was some kind of advance," which is obviously crazy wrong, zeroing out the spherical aberration of an eye. So it's kind of interesting how it's all come back to spherical lenses.
So, two comments.
Yeah, please, but we must finish the discussion soon, and let also comment Pablo just to balance this discussion. Yeah. Please, George.
But just two quick comments. Number one, back in the 90s, not only did we use spherical lenses, we also targeted minus 50, minus 75, which was the ideal thing. We didn't know that. We just said, let's not make them hyperopic, let's make it myopic. And in actual fact, we were helping them. So, that's the important thing, right? Pablo, your lens is a fantastic lens. The only question I ask is, does decentration come into play when you're looking at the peripheral meniscus lens?
No, actually, it's pretty resistant to small decentrations. So it's really amazing how nicely it's working. So for a standard small amount of decentrations, everything seems to be working as well as with very well-centered lenses, right? Another couple of advantages of these meniscus lenses is, and some people believe this is important, is practically, I think you reduce all these negative dysphotopsias at very far periphery that some people are very nervous about. And there is no reflection, right? So other people are, for some powers of the lenses, standard lenses, that you can have reflections and some patients are very unhappy. With these meniscus lenses, you are not going to have reflection for any power. So that's another small thing. But I'm very happy to be with you. This panel is just, I would like to believe Dan, but I don't think most people I meet, more of your colleagues, they are so happy with trifocal lenses that they cannot consider anything else. They are like so I would like to believe you, but I think the reality is that the majority of ophthalmologists in many countries are really promoting very strongly diffractive lenses, right? And for me, it's very strange from the point of view of the quality of life of the patients, because it's obvious that it's not good for the patients in the long term, in many cases, just after the surgeries. So, but it's a consensus, right? I think, except a few like you, I believe it's a consensus that, okay, this is, I can't say that many people believe this is good for the business, this is good for us. That's all, right?
Dear colleagues, we must continue this discussion. It is very interesting, very good. I promise that next time I will provide much more time for the discussion as we see it is needed. Now,
I just want to know when Pablo's lens is going to be available generally. It sounds very interesting to try.
Yeah, you can. They are available in Europe already, so you can. And we are very happy to provide samples just for everybody to try and make suggestions. So just contact me and you get lenses.
Thank you again. Thank you for great presentations and very good discussion. Thank you again.
Okay.
Thanks for the invitation, Andrzej. It's been great to be with you.
From Canada to Australia, through Spain and in the UK. Incredible. Thank you so much.
Bye-bye.
Worldwide.